Hello, I'm Minju Kuruvilla, and this is the second lecture on neonatology for the Pass Test MRC-BCH Part 1 course. This lecture is on metabolic, hematologic, and infectious conditions in the newborn. The learning objectives of this lecture are to gain an overview of the causes and management of common neonatal metabolic conditions such as hypoglycemia and jaundice, to learn about common hematologic problems in the newborn, and to gain an understanding of the presentation of common congenital infections. So let's start with a question. Neonatal hypoglycemia is seen in all of the following except A. Small for gestational age, B. Infant of diabetic mother, C. Septo-optic dysplasia, D. Birth asphyxia, E. Hemorrhagic disease of the newborn. And the answer is E. Hemorrhagic disease of the newborn. Small for gestational age babies are prone to developing hypoglycemia due to lower glycogen stores. Infants of diabetic mothers have higher levels of circulating insulin and are also prone to developing hypoglycemia. Septo-optic dysplasia is associated with pituitary dysfunction and can result in hypoglycemia. In birth asphyxia, hypoglycemia can be both due to glycogen depletion secondary to catecholamine release and also due to hyperinsulinemia. Hemorrhagic disease of the newborn is due to vitamin K deficiency and is not associated with hypoglycemia. Neonatal hypoglycemia is common and may be asymptomatic. A blood sugar level of 2.6 millimoles per liter is generally agreed as the level below which is termed hypoglycemia. It's essential that neonates who are at high risk of developing hypoglycemia be appropriately screened in order to prevent prolonged hypoglycemia. It has been shown that severe prolonged hypoglycemia may cause a poor neurodevelopmental outcome. Hypoglycemia in neonates is seen in a number of conditions and circumstances. The list is quite exhaustive, but it's generally easier to remember the causes of hypoglycemia if you divide them into various groups. So for the purposes of this lecture, I have divided the main causes of hypoglycemia in newborns under the following sections. The first, and probably one of the most common causes of hypoglycemia seen in the newborn, is due to decreased glycogen stores, and this is seen in prematurity and intrauterine growth restriction. The second group is hyperinsulinism, and as we mentioned earlier, seen in infants of diabetic mothers or in conditions such as Beckwith-Wiedemann syndrome or insulin-producing tumors. Endocrine causes of hypoglycemia would include adrenal or hypothalamic deficiency, congenital hypopituitarism, or septo-optic dysplasia. Coming to the more rare causes, metabolic conditions that cause hypoglycemia are less common. Grouped under this category would be glycogen storage disorders, galactosemia, and disorders of amino acid metabolism. Finally, other causes of hypoglycemia include perinatal asphyxia, sepsis, hypothermia, polycythemia, and the maternal use of propranolol antenatally. This slide gives a list of the common clinical features associated with hypoglycemia. As I mentioned earlier, hypoglycemia can be asymptomatic, and it's important to screen and manage babies who are at high risk. So infants who are born prematurely and those who are small for gestational age should be commenced on oral feedings shortly after birth, if at all possible. If hypoglycemia persists despite oral feeds, or if there's severe initial hypoglycemia, these infants need to be commenced on intravenous dextrose. The amount of dextrose that each individual baby requires varies. depending on the level of hypoglycemia and, more importantly, on the level of circulating insulin. It's important to note that in newborns, dextrose concentrations of up to 12.5% can be given via peripheral veins. If these infants need higher concentrations of dextrose, these would have to be given by a central line. It's usually infants with hyperinsulinism who require higher concentrations of dextrose, and in addition, they may require glucocorticoids and diazoxide to manage the hypoglycemia. Okay, now moving on to the theme of neonatal jaundice, another common condition seen in neonates. The next 3 slides have 3 different case scenarios. For each of them, select the most likely diagnosis from the list provided. So in the list we have A. Physiological jaundice, B. G6PD deficiency or glucose 6-phosphate dehydrogenase deficiency, C. ABO incompatibility, D. Crigler-Najjar syndrome, E. Congenital hypothyroidism, F. Hereditary spherocytosis, and G. Rhesus incompatibility. So the first scenario, a term male baby presents on day 5 with jaundice, vomiting, poor feeding, and hypotonia. Initial investigation results show a total bilirubin of 660 micromoles per liter with a conjugated fraction of 18 micromoles per liter. The baby's blood group is O rhesus negative. The mother's blood group is O rhesus positive. The direct Coombs test is negative. Hemoglobin is 8.7 grams per deciliter. The blood film shows reticulocytes, and thyroid stimulating hormone was 4.1 milliunits per liter. So, picking up on the salient points in this scenario, we have a term male baby presenting on day 5 with an extremely high unconjugated bilirubin level and anemia. Note that most neonatal units would consider treating term babies for jaundice when the level approaches 300 micromoles per liter. The blood film shows reticulocytes, and this indicates a high marrow turnover and hence hemolysis. There's no setting for Rhesus incompatibility, as the mother is Rhesus positive and the DCT is negative, nor is there an ABO setting. The thyroid stimulating hormone level is within normal limits. Hence, the most likely diagnosis is B. Glucose 6-phosphate dehydrogenase deficiency. The clues here are the sex of the baby, as G6PD is inherited as an X-linked recessive gene, and the severity of jaundice and anemia, as the condition can result in severe hemolysis. Moving on to the next scenario, we have a well-term baby girl who presents with jaundice at 4 days of age. The initial investigations show a total bilirubin of 310 micromoles per liter with a conjugated fraction of 8 micromoles per liter. Her blood group is A rhesus negative. Her mother's blood group is O rhesus positive. The direct Coombs test is negative. The hemoglobin is 14.7 grams per deciliter. The blood film shows a few spherocytes and reticulocytes, and the thyroid stimulating hormone is 2.3. Once again, picking the salient features from this scenario, we have what appears to be a well-term baby presenting at 4 days of age with an unconjugated hyperbilirubinemia. Her blood film demonstrates evidence of hemolysis in the form of spherocytes and reticulocytes, and there is a setting for ABO incompatibility, as in her mother's blood group is blood group O and her blood group is blood group A. The thyroid stimulating hormone is within normal limits. The most likely diagnosis in this situation is C, ABO incompatibility. ABO incompatibility causes a hemolysis which is milder than that caused by Rhesus Incompatibility, and the direct Coombs test need not be positive. The clues in this scenario are the ABO setting, the unconjugated hyperbilirubinemia, and evidence of hemolysis in the blood film. The third scenario is a 16-day-old baby girl who was born at 35 weeks gestation, who was investigated for jaundice. Her total bilirubin is 180 micromoles per liter. Her blood group is O, Rhesus positive, and her mother's blood group is B, Rhesus positive. The direct Coombs test is negative. Her hemoglobin is 15.5. The blood film was normal, and so is her thyroid stimulating hormone. So the salient features here again are a preterm baby who was born at 35 weeks gestation, presenting at just over 2 weeks with jaundice. She seems otherwise well, and her investigations show an unconjugated hyperbilirubinemia with a normal hemoglobin, blood film, and TSH. There is no setting for either ABO or Rhesus Incompatibility, and the direct Coombs test is negative. The most likely diagnosis in this situation is A, physiological jaundice. We will be speaking about physiological jaundice in a minute, but it's important to note that preterm babies can have high bilirubin levels for slightly longer than term babies, and hence prolonged jaundice is considered after 3 weeks in preterm babies as opposed to 2 weeks in term babies. Let's spend a few minutes talking about jaundice in the newborn. As I mentioned earlier, most newborns have a certain degree of hyperbilirubinemia, though not all of them need treatment for it. There are a number of reasons why bilirubin levels are high in newborns compared to older infants or children. Bilirubin is derived from the breakdown of heme-containing proteins, mainly hemoglobin. Bilirubin is water-insoluble and hence needs to be conjugated in order to be rendered water-soluble and thus excreted. Conjugation occurs in the liver, and excretion is in the urine and feces. Some of the reasons attributed to increased levels of neonatal hyperbilirubinemia are 1. Increased bilirubin production, and this is due to the increased red cell volume and decreased lifespan of red cells in the neonate, and increased ineffective erythropoiesis. Another factor that contributes to higher levels of bilirubin is the increased Androhepatic circulation. This refers to the process where conjugated bilirubin is excreted in the bile into the intestines, then gets deconjugated and is reabsorbed into the bloodstream. Androhepatic circulation is higher in newborns due to decreased levels of intestinal bacteria and decreased gut motility. Other causes of a raised unconjugated bilirubin level in the bloodstream include defective conjugation and impaired excretion. So, this jaundice seen in well newborns is referred to as physiological jaundice, and it's characterized by onset between 24 and 72 hours of life. It peaks between 3 and 5 days. The levels normalize by 2 weeks in term babies and 3 weeks in preterm babies. The jaundice is unconjugated, and the rate of rise of bilirubin is usually slower but persists for longer in preterm babies. Therefore, the features of non-physiological jaundice are jaundice appearing on day 1, conjugated hyperbilirubinemia, which suggests obstruction to biliary excretion into the intestine, and prolonged jaundice. The most common causes of non-physiological jaundice include hemolytic anemias like glucose 6-phosphate dehydrogenase deficiency, pyruvate kinase deficiency, and hereditary spherocytosis, Rhesus and ABO incompatibility, infections, breast milk jaundice, hypothyroidism, galactosemia, and biliary atresia. Okay, let's move on to another question. Question 3. The following are recognized causes of hypocalcemia in the newborn. A. Maternal hypoparathyroidism. B. Maternal diabetes. C. DiGeorge syndrome. D. Hypermagnesemia. And E. Hypophosphatemia. Neonatal hypocalcemia can be either early onset or late onset. Early onset neonatal hypocalcemia occurs secondary to prematurity, maternal diabetes, and birth depression. Late onset hypocalcemia, usually after 3 to 5 days, may be due to hypoparathyroidism, which is transient, idiopathic, or congenital, as in DiGeorge syndrome, maternal hyperparathyroidism, and hypomagnesemia. It can be due to vitamin D deficiency, secondary to maternal vitamin D deficiency, liver or renal disease. It can be due to rapid postnatal growth, hyperphosphatemia, as this impairs the conversion of vitamin D to its active form. Other causes include loop diuretics, alkalosis, and hypoalbuminemia. So if we were to go back to the question, the answers would be maternal diabetes and DiGeorge syndrome. Maternal hyperparathyroidism, hypomagnesemia, and hyperphosphatemia all cause hypocalcemia. Okay, here's another question. Question 4. A well breastfeeding term infant presents with jaundice at 36 hours of age. The serum bilirubin was 286 micromoles per liter. The direct Coombs test is negative. Blood film showed spherocytes and reticulocytes. The baby's blood group was A rhesus negative and the mother's blood group O rhesus negative. Which of the following is the most likely diagnosis? A. Rhesus hemolytic disease. B. ABO incompatibility. C. Hereditary spherocytosis. D. Physiological jaundice. Or E. Breast milk associated jaundice. The bilirubin level at this age is too high for physiological or breast milk associated jaundice, which both tend to present later. Rhesus hemolytic disease is not possible as the baby is rhesus negative. Spherocytes and reticulocytes are seen commonly on the blood film in ABO incompatibility. The direct Coombs test is sometimes negative in ABO incompatibility, reflecting a low concentration of antibody on red cells compared to rhesus incompatibility. So the most likely diagnosis here is B, ABO incompatibility. Moving on to hemorrhagic disease of the newborn. Let's start with a question. Question 5. Which of the following are true regarding hemorrhagic disease of the newborn? A. It is more common in formula-fed infants. B. It is more likely to occur in breastfed infants if the mother is being treated with heparin. C. Usually presents with petechiae. D. Leads to prolongation of the prothrombin time. Or E. Can be prevented by treating babies with vitamin K at birth. Hemorrhagic disease of the newborn is caused by vitamin K deficiency. Vitamin K crosses the placenta poorly, and breast milk contains low levels of the vitamin. Maternal liver disease and anticonvulsants like phenytoin and phenobarbital increase the risk of vitamin K deficiency. Vitamin K is involved in the carboxylation of glutamate residues of a number of proteins, including clotting factors 2, 7, 9, and 10. Hence, a deficiency would result in deranged clotting. Early onset hemorrhagic disease of the newborn presents within the first 48 hours, usually with gastrointestinal bleeding. The prothrombin time and activated partial thromboplastin time are both prolonged, as both the intrinsic and extrinsic pathways are affected. maternal heparin therapy does not contraindicate breastfeeding. So the true statements in this question would be D and E. Question 6. You attend an urgent emergency section for a 36-week premature delivery. The mother presented with bleeding, decreased fetal movements, and an abnormal CTG. On arrival on the labor ward, you find a pale infant with respiratory distress. The initial hemoglobin of the baby is 7 grams per deciliter. The mother had fetal ultrasound scans at 12, 20, and 35 weeks gestation, all of which were normal. The mother's blood group is O positive. She has a normal autoantibody, rubella, syphilis, and HIV screen. What is a possible cause for this baby's anemia? A. Rhesus Incompatibility. B. Fetal-maternal hemorrhage. C. Physiological anemia. D. Maternal anemia. E. Placental chorioangioma. Anemia in the neonatal period can be due to a number of causes. In this example, the most likely diagnosis is fetal-maternal bleeding, and this can be confirmed by performing a Kleihauer test, which identifies the presence of fetal blood cells in the maternal circulation. Rhesus incompatibility, though a cause of anemia, is unlikely in this instance as the mother's blood group is O positive with negative antibody test. Severe maternal anemia is likely to result in a growth-restricted infant rather than produce neonatal anemia. The next couple of slides goes through the causes of anemia in the neonatal period. There is quite a long list of causes of anemia in neonates, but I found an easy way of remembering these if you classify them into causes of blood loss, increased destruction of red cells and therefore hemolysis or hemolytic anemias, or decreased red cell production. So causes of blood loss again can be divided into obstetric causes such as abruptio placentae, placenta previa or cord rupture, or fetal blood loss where there's fetal-maternal bleeding or twin-to-twin transfusion, or finally neonatal blood loss such as intracranial hemorrhage, massive cephalomatomas or subgaleal bleeds, or adrenal, renal or GI bleeding, or finally iatrogenic. Common causes of hemolysis in neonates are immune hemolysis due to ABO or Rh incompatibility. Hemolytic anemias that can present in the neonatal period include hereditary spherocytosis, G6PD deficiency, and pyruvate kinase deficiency. Causes of acquired hemolysis would include sepsis. Reduced red blood cell production is seen in physiological anemia, which usually presents at 8 to 12 weeks of life, congenital infections, and less commonly in congenital leukemia or Diamond-Blackfan syndrome. Question 7. Bacterial sepsis in the first few days of life is associated with which of the following? A. Conjugated hyperbilirubinemia. B. Prenatal dexamethasone. C. Maternal insulin-dependent diabetes. D. Thrombocytopenia. Or E. Prolonged rupture of membranes. Bacterial sepsis in newborns usually leads to an unconjugated hyperbilirubinemia. Congenital viral infections can lead to a conjugated hyperbilirubinemia. Antenatal steroids and maternal diabetes do not increase the risk of infection. Thrombocytopenia and prolonged rupture of membranes, however, are associated with the development of neonatal infections. So this slide lists the risk factors for neonatal sepsis. These include rupture of membranes, intrapartum maternal fever, fetal tachycardia, chorioamnionitis, preterm delivery, and maternal colonization with group B streptococcus. Each risk factor represents approximately 1 to 2% risk of infection to the baby. So if a baby is born with 2 or more of these risk factors, you should have a low threshold for screening the baby for infection and commencing antibiotics. Question 8. The following increase the risk of vertical transmission of the the human immunodeficiency virus? A. A high maternal CD4 count. B. Twin pregnancy. C. Prolonged rupture of membranes. D. Preterm birth. Or E. Caesarean section. Approximately 1/3 of vertically transmitted cases of human immunodeficiency virus are transmitted across the placenta, and 2/3 during birth. The risk of vertical transmission is increased by low maternal CD4 counts, high maternal viral load, rupture of membranes, preterm birth, vaginal delivery, and no or inadequate maternal antiretroviral treatment. With maternal antiretroviral treatment during the 3rd trimester and to the baby for the first 6 weeks of life, without these risk factors, vertical transmission can be reduced to less than about 2%. So the answers are prolonged rupture of membranes and preterm birth. Okay, here's question 9. Which of the following statements about congenital rubella syndrome are true? A. It's the most common cause of congenital infections. B. Infection of the fetus is most likely if the mother gets infected in the 3rd trimester of pregnancy. C. Is commonly associated with fetal anemia and high drops. D. Congenital heart disease is a feature. Or E. Is associated with pathognomonic cerebral calcifications. The answer is D. Congenital heart disease is a feature. CMV is the most common cause of congenital infections. Rubella infection of the fetus is most likely if the mother gets infected in the 1st trimester. Fetal anemia and high drops are more commonly seen in parvovirus infection. And finally, cerebral calcifications are seen in CMV and toxoplasmosis. Let's spend a few minutes talking about congenital infections in the next slides. Let's start with rubella. The risk of congenital infection with rubella is about 80% if the mother has a primary infection early in the 1st trimester. This risk drops to about 50% in the 2nd trimester. The incidence of congenital rubella has dropped dramatically in recent years due to widespread rubella immunization. As you can see, the list of clinical features is very long, and I won't enumerate them. Cytomegalovirus, or CMV, is the most common cause of congenital infections. The risk to the fetus is higher with primary infection, about 40% resulting in fetal infection, as opposed to 1% following a maternal recurrence. The infection can affect the fetus at any stage of the pregnancy, and again, we have a long list of clinical features, but periventricular calcifications are quite characteristic. Toxoplasmosis is transmitted from the infected mother to the fetus in about 40% of cases. The intracranial calcification in toxoplasmosis is different to that seen in CMV infection, as it's a diffuse cerebral calcification. Congenital parvovirus B19 infection can result in spontaneous abortion, fetal anemia with high drops, stillbirth with high drops, or sometimes fetal asymptomatic infection. About 25% of infected mothers transmit varicella infection to the fetus, though less than 5% of infants born to mothers with gestational chickenpox demonstrate the stigmata of the disease. Perinatal chickenpox, on the other hand, is a more serious and potentially life-threatening disease. Approximately a quarter of babies will become infected if their mother develops chickenpox in the peripartum period. Maternal chickenpox within 5 days of birth presents the greatest risk, as there is insufficient time for transplacental transmission of antibodies. Administration of the varicella zoster immunoglobulin within 72 hours of exposure has been shown to prevent and attenuate chickenpox in this group of infants. So that brings us to the end of this lecture. I hope I've been able to give you an understanding of causes and presentation of common neonatal metabolic problems like hypoglycemia, jaundice, and hypocalcemia. I hope I've familiarized you with the presentation and management of common hematologic conditions in the newborn and given you an overview of neonatal infections. Thank you.